Hello, everyone, and welcome to the Radiology Cardiothoracic Imaging podcast. My name is Sonia Barra, and I'm the editor-in-chief of the journal Radiology Cardiothoracic Imaging. The host of our podcast is Praveen Ranganath from Dallas, Texas.
Hey, Dr. Ibarra. Hello, everyone.
Hi, Praveen. In this series of podcasts, we will break down recent articles and trending topics from the journal through conversations with the authors, the editors, and experts in the field. For all of you out there interested in cardiothoracic imaging, subscribe and listen to the podcast to keep up to date with recent developments in cardiothoracic imaging.
Hello again, listeners, and welcome back to the Radiology Cardiothoracic Imaging Journal podcast. I am your host, Praveen Ranganath. On today's episode, we will be discussing a recently published original science paper in the journal. The paper is titled Cost Effectiveness of Management Algorithms for Lung-RADS Category 4 Nodules. This paper comes to us from our colleagues at the Brigham and Women's Hospital in Boston, Massachusetts. The lead authors are Dr. Mark Hammer and Dr. Sumit Gupta. The senior author is Dr. Chung Yin Kong. Whether we like it or not, pulmonary nodules are an important part of our lives as cardiothoracic imagers. And certainly many in our audience have encountered suspicious nodules that are challenging in terms of selecting the best of the many available management approaches. Many guidelines for managing pulmonary nodules exist, including those from Lung-RADS, the British Thoracic Society, and the American College of Chest Physicians, among others. The featured publication is a retrospective single-center study comparing the cost-effectiveness of different guideline-driven strategies in managing suspicious pulmonary nodules, specifically for Lung-RADS 4 nodules. This publication elegantly combines principles from lung cancer screening CT, simulated patient cohorts, and population health. On today's podcast, I have the privilege of speaking with the lead author of the featured paper, Dr. Mark Hammer. We discussed the fundamentals of cost-effectiveness research, the featured study's methodology, and the implications of its results. Spoiler alert, of the strategies included in the analysis, only the British Thoracic Society and Lung-RADS guidelines were cost-effective. How did they reach this conclusion? Well, let's jump into my conversation with Dr. Hammer now and find out. Hello, listeners, and welcome back. I am privileged to be joined by the esteemed Dr. Mark Hammer, who is the lead author of this episode's featured publication. As a reminder, the title of that article is Cost Effectiveness of Management Algorithms for Lung-RADS Category 4 Nodules. Mark, thank you very much for joining us on the podcast.
Thank you for having me.
Excellent. Well, first, why don't we learn a little about you? Mark, where is it that you practice currently, and what are your areas of academic interest?
Sure. Well, I'm one of the thoracic imagers at the Brigham and Women's Hospital in Boston. My areas of research interest, I guess, primarily focus on triage of pulmonary nodules and sort of lung cancer screening associated questions, but I also have some interest in lung disease in immunocompromised patients and mediastinal masses and other things like that. So there's quite a lot of interest, but my main focus is on pulmonary nodules.
And fantastic. And what got you into the cost effectiveness space within lung cancer screening?
Yeah, that's a great question. I had never done anything like that before I came to the Brigham. And soon after I joined here through some sort of random circumstances, basically, I got connected with my collaborator, Dr. Joey Kong, who at the time was at MGH and has since moved to Mount Sinai. But he was doing cost effectiveness research and a lot of research into lung cancer screening. So let me explain a little bit about cost effectiveness analysis and kind of, what it is at least, and we can kind of get into more details. So the question is, whenever we look at a type of intervention or management strategy for a patient, we should wonder, what are we accomplishing and how much does that cost, right? And so ideally, what we are accomplishing is to lengthen the patient's life expectancy or improve their quality of life. We sort of in the jargon, we say quality associated adjusted life year, QALY. And so that's the thing that we want to increase. And, as with all things, there's a cost to that. And so what we want to do is make sure that our interventions are cost effective, meaning that they give the greatest amount of extra quality adjusted life years for the smallest amount of cost.
Excellent. So how then would you associate QALY? Am I saying that right? Quality adjusted life years. How would you associate QALY with the intervention of lung cancer screening? Can you kind of flesh out that association a little more for us?
Yeah, absolutely. Right. So, a little bit peripherally associated with what we're going to talk about in detail in a bit, but with lung cancer screening is a great example of a cost-effective intervention. So I think it's good to sort of illustrate what we're talking about. So as probably most of your listeners know, there was a big trial, the National Lung Screening Trial, which is a randomized controlled trial, which randomized patients to chest x-rays versus CT, low-dose CT for lung cancer screening. And it showed that there was a survival benefit in the CT arm. And therefore, we conclude that, that low-dose CT is effective for lung cancer screening. In other words, patients live longer. But you might then ask, and a lot of policymakers ask, in every country have asked, how much does that cost, right? There's a lot of pushback on, we're going to do 1 million CTs on all of these patients, and that's going to cost a lot of money. And remember that there's downstream costs, right? You find a pulmonary nodule, if it's big enough, you might do a PET, you might do, and we'll get into this kind of detail in a bit, but you might do a biopsy, you might do a surgery. These things, of course, cost money, and some of them even also impact patient life expectancy. But the main thing for my point here is that they cost something. And so beyond the randomized trial, someone should then come and do a cost effectiveness analysis saying, okay, we know that this intervention improved these patients' life expectancy, but at what cost does our government have to pay for those with government healthcare, which will include most of the people here who are old enough, not all, but many of the people are old enough to be eligible for lung cancer screening. So the government's got to pay out this money, and the government wants to know, what am I getting for my money? And so that's when you're going to do a cost effectiveness analysis. So basically what you do is you take all of the patients in your cohort, and often this is done with simulation for reasons I'll explain in a second, but you take all the patients in your cohort and you say, all right, here's how long each of them lived. We can then average that. And here's how much each of the interventions cost. And not just interventions, but their total cost. So biopsies and PET scans and follow-up CTs. And also we look at the cancer associated costs. So how much of their cancer treatment costs, because ideally if we're catching cancers earlier, the cancer treatment cost is going to be less than if we, don't catch it until they're stage 4. That's obviously much more expensive. So you're going to look at everything essentially until the patient dies. There's different ways of doing this for shorter time periods, but generally going to look until the patient dies, and then you add up that. So that's your cost. And then you can basically say, what's the cost effectiveness? So you're going to say, how many dollars did you spend for each additional quality adjusted life year that you gain? Cost divided by quality, and that gives you the cost effectiveness ratio. If you're going to compare two different interventions, you can get what's called we'll talk about this more, incremental cost effectiveness ratio, or ICER, which just tells you how much. So let's say my baseline intervention was screening with X-rays. My second intervention was screening with CTs, because X-rays had some efficacy, although poor. How much more did I have to pay for the CTs versus how many more life years did we gain?
Got it. And with regards to your specific publication on this episode, it looks like you focused on large pulmonary nodules. Can we briefly review what a large pulmonary nodule is using Lung-RADS as our baseline?
Sure. Yeah. So we, in the paper that we're talking about here, we looked at cases that were Lung-RADS category 4, so 4A, 4B, 4X. And these are large pulmonary nodules. The cutoffs depend a little bit on the whether it's baseline or whether it's sort of the interval surveillance. And it also depends a little bit on whether it's a solid nodule or a subsolid ground glass, or actually no pure ground glass should really be in that category, part solid nodule. So, your readers can look up the Lung-RADS criteria for reference, but kind of the general idea is that, if it's at baseline, then the nodule has to be at least 8 millimeters if it's a solid nodule, or if it's growing, then it can be smaller than that. And so the reason that I focus on large nodules is, to me, that those clinically represent our biggest challenge, because you feel like you have to do something generally for those nodules. It's not just the standard, all right, come back in a year, right? Yeah. These are nodules that are big enough that they could represent clinically significant cancers for the patient. They have the potential for growing rapidly and developing metastatic disease in a short interval. And so we don't want to miss the cancers, but it's a challenge because, some of those are going to be infections. Some of those are going to just be a granuloma or hematoma or something like that. And so these are really the ones where the rubber meets the road, and some action of some sort needs to be taken. It might just be follow-up, but some action needs to be taken. And so these represent the biggest challenge in my mind when I'm reading a case clinically. And so that's why we focus on that. Lung-RADS itself gives you several options for treating these nodules. It doesn't really go into much detail about which option you should pick for any particular case. Unfortunately, again, this is why I find this topic interesting, right? You have the option of getting a follow-up CT, depending exactly which category you are, either in 1 month or 3 months. This would probably be for cases where you think, oh, maybe it's an infection, maybe it'll go away. Or if you think, oh, this is maybe a benign nodule, let's keep following it. If it's stable, then we're fine, right? You have the option of doing a PET scan, right? And you have the option of potentially biopsying or sending the patient to a thoracic surgeon for excisional biopsy, excisional treatment of the lung cancer. If it's a speculated nodule that's 15 millimeters, right? We were just going to say, well, you should probably see a surgeon. You know?
It's a slam dunk.
Just go for it. Obviously, there's a big spectrum in between this is probably benign, this is probably malignant, and it's a big challenge for us to decide in a lot of cases what to do. And again, the Lung-RADS guidelines do not really specifically tell you, in any individual patient, this is what you should do. So this is why we were focusing on this question.
Interesting. So your work actually compares cost effectiveness between several different management strategies for these large pulmonary nodules. Can we review what these management strategies are in general and explain some of the major differences between them?
Yeah, that's a great question. So, in radiology, we are probably most familiar with two guideline systems for managing pulmonary nodules. One of them is the Fleischer Society guidelines, which are intended for incidental nodules outside of the context of lung cancer screening, and Lung-RADS, developed by the American College of Radiology, which is designed for nodules detected within lung cancer screening. They're actually relatively similar. I mean, obviously there's some small differences in them, but they're sort of overall pretty similar in the way they approach the nodules, which is basically to use size criteria for kind of branch points in their algorithm. Now, there are some other guidelines that have been developed by different societies. We have the American College of Chest Physicians, which is a group of pulmonologists mostly, and they've developed a guideline, which is a rather complex algorithm that if people are interested, they can obviously look at the primary literature, or we, in our supplement to this article, we have a little diagram of how I sort of interpreted their algorithm. And then there's the British Thoracic Society, which is a group of people from the UK, obviously, who I think includes both pulmonologists, surgeons, and it's a multidisciplinary group. And they also develop a rather complex algorithm. Again, I suggest people look at either the primary literature, or again, we've sort of put our little interpretation of the algorithm in a supplement of our paper. But so these are all different guidelines, and the question is, well, what's sort of the overall difference? What's the different approach? So as I mentioned, Lung-RADS really focuses on size criteria, and then once it's above a certain size, it kind of gives you leeway to choose your path. It does not really specify this patient has to get a PET, this patient has to get a biopsy, etc. Now, the American College of Chest Physicians, or ACCP, and the British Thoracic Society, or BTS, those guidelines are a lot more detailed. They are really like, this point, this point, this point, this point. And so the other major distinction here is that they use risk calculators. So what's a risk calculator? A risk calculator is obviously a calculator. Usually they take just a couple of little sort of inputs, some checkboxes, some continuous numbers that you'll input, and it spits out a percentage that is the estimated likelihood of this nodule being malignant. These risk calculators might include patient information like age, demographics. They might include some information about the lungs. Do you see emphysema? They're going to include the nodule size, of course, but they may include other information like nodule location, speculation, etc. The most well-known of these calculators is the calculator developed by Brock University in Canada. This was published in the New England Journal in 2013. This was based on data from the Canadian lung cancer screening trial. It's called Pan-Canadian Lung Cancer Screening Trial. So they had information about all the nodules in that trial, and it was a large number of nodules. And so they were able to develop this risk calculator, which has been subsequently validated in several other lung cancer screening cohorts. And so it's a pretty well accepted calculator, and so that's why it gets wide usage. So as I sort of alluded to, it will look at patient age, patient sex, presence of emphysema, family history of malignancy, nodule size, nodule density, meaning is it solid or ground glass, et cetera, is it spiculated? And so using, and the location, so is it in the upper lobes or is it not? And so combining all of that information, it's going to spit out a value. Now, the important thing to know about this and most other risk calculators and other management algorithms that may have been evaluated, they're intended for use for all nodules. And so they're often evaluated on just a group of patients with nodules, right? 1,000 patients who have pulmonary nodules, right? And so, as probably most of your readers are aware, most of the nodules that we see are very small, right? They're very small and they're benign. That's the vast majority of all nodules that we see. In our paper, we focused, of course, on the large nodules and the suspicious nodules, which we'll get to in a second, but realize that these calculators have been developed and validated in cohorts where the majority of nodules are very small and are benign. And so there's a big question of whether these calculators, whether they are as accurate, as effective in the larger nodule group. So the ACCP and BTS guidelines use the Brock model as their first triage point. And then the BTS guideline also uses another pulmonary nodule risk calculator for evaluating the PET scan results. So if you get a PET scan within the BTS guidelines, you should use this so-called Herder model to evaluate the risk of malignancy at that stage, which incorporates PET scan results as well as other information such as nodule size, etc. The ACCP guideline just uses the PET scan, pretty basically positive, negative kind of thing. So they don't incorporate the other factors at that later point in their algorithm.
Got it. So at risk of oversimplifying, your work has compared some of the more rudimentary management algorithms that are primarily size-based with some of the more sophisticated algorithms that include a variety of different patient characteristics, nodule characteristics, et cetera. Let's set the stage a little bit more with regards to your methodology before we dive into the results. So from what I understand, you've taken raw patient data from a random subset of about 151 patients from a pool of patients at your institution that underwent a low-dose lung cancer screening CT from 2010 to 2018. And those patients had a Lung-RADS 4 category nodule on them. From these patients, you then created a simulated cohort of 100,000 patients on which you subsequently performed the effectiveness and cost-effectiveness analyses. Without getting too much into the weeds of the technical details, how did we get from those 151 patients that were real patients to the 100,000 simulated patients?
Yeah, that's an excellent question. I would just say that in general, just as a little preamble, that most cost-effectiveness analyses do end up using some type of simulation. And the reason is that if you're going to compare a bunch of different management strategies, it's often not practical to do all of those in the setting of a randomized trial on real patients. It may just be very unwieldy. You want to try 10 different algorithms. You obviously can't get so many patients. Or some things you might want to test would be unethical, such as, one of the simple strategies we just tested in our paper was only doing follow-up. So patient presents with a nodule, you're just going to go first to follow-up. Well, obviously that's not going to happen in real life, right? So there are strategies that one can test with simulation that one cannot test in a randomized trial setting. So you're pretty much always going to have some component of simulation in your cost effectiveness analyses. Now, some of the cost-effective analyses use what I might say is like a first principles sort of design, where you simulate the natural history of a lung cancer. You have a model of that, and you use that information that you get from literature and various assumptions to model the growth of a lung cancer, and then you can model how might a CT scan pick it up and how might it, various interventions affect the patient, et cetera. So that's a very rather complex type of simulation, and that's the sort of simulation that I've done in some other work with Dr. Kong. For this particular paper, we used real patient data, but we did some amount of simulation on top of that. In this case, we had 151 real patients with Lung-RADS 4 nodules, but unfortunately, there was some information missing that we would need to apply the ACC, particularly the ACCP and BTS strategies, which is that only about half or so of the patients had PET scans, and not all, I forget what the exact number is, maybe a third or something, didn't have a follow-up CT that we could use. And so we would need that information to really be able to accurately apply these other management algorithms, which might require that step as part of their algorithm. So what we did was what we call imputation. In other words, we sort of estimated what the likely result of a PET scan would be for that particular nodule. And how do we do that? Well, I took all of the nodules that we had with PET scan results, and I said, all right, we're going to make a multivariable logistic regression analysis looking at what factors predict whether the PET scan would be positive. So obviously, because we know whether the nodules are malignant or benign, so whether the nodule's malignant, obviously more likely to be PET positive, nodule size, and some other criteria, which I've detailed in the supplement of this paper. But using that model, we can then estimate what the PET scan result would have been for a patient in which we don't actually have that information. The patient never got a PET scan. However, presumably there's going to be some error rate, right? Presumably we're not 100% right on whether the PET scan would have been positive or not. And so what I was able to do using 100,000 simulated patients was to say, all right, well, each time I select, so these 100,000 was selected with replacement from the 150. So in other words, each time it just randomly selected one patient out of the 150 patients that we had. And if the patient had all of their PET scan results, so fine for them to just put into the cohort. But if it was a patient in which we didn't have the PET scan result, we would then use that logistic regression model to predict what the PET scan would have shown. That is a random prediction. I mean, it's based on there's a likelihood for the different values, but it was done randomly each time. So for a patient in whom we didn't know the result, they actually had different random results each time we picked them out of that 150. So the 100,000 patients was actually, there weren't all identical copies. For the patients in whom we didn't have the raw data, we actually generated randomly different results.
Got it. And does that relate at all to the sensitivity analyses that you've described in the methods of your paper too?
To some degree it does, yes. So sensitivity analyses are the way that we tend to evaluate cost effectiveness analyses. So as I mentioned, there's a lot of assumptions that go into these models, right? There are assumptions about simple things like how much does it cost to, for cancer treatment, or how long is a patient's life expectancy. But there are more complicated things such as, for example, what's the likelihood that a PET's going to be positive in a malignant nodule? What is the false negative rate of biopsies? All stuff like that. And so sensitivity analyses are going to basically be where you change the sum of the parameters in your model and you see, all right, does that change the outcomes in terms of cost effectiveness of the strategies that we tested? And so we did do some changes in, well, one thing I did was just redo the entire 100,000 simulated cohort a second time, just to make sure that there wasn't anything weird about the first time that we did it, because it's random. We also did a case in which we increased the false positive rate of PET. And then there were several other sensitivity analyses that we did, because again, our sort of estimates here have some amount of error. And so we want to see how much does the expected error in our assumptions, how much would that really affect the overall conclusions that we make about cost effectiveness?
Great. Okay. I think this has set the stage really well in terms of methodology. Let's start breaking down the cost effectiveness analysis data. So the big takeaway for me here is that the BTS and ACCP management strategies did result in a larger amount of quality adjusted life years and a higher incremental cost effectiveness ratio, or ICER. The finding was obviously robust after multiple of the sensitivity analyses that we just mentioned. So my takeaway here is BTS and ACCP strategies were more cost effective than some of the others. But the differences in quality between these strategies and all of the others was pretty small. At least, I'm not super familiar with cost effectiveness analysis work, but to me, it seemed relatively small. So is there really a substantial difference between these strategies, or are we splitting hairs here?
Yeah, that's a great question. So one small point of clarification is that, so you're right, that the BTS and ACCP guidelines gave the highest quality adjusted life years. However, the ACCP guideline itself was actually not cost effective. And so let me go back and just tell everyone a little bit more detail about how we do the combined cost effectiveness part, right? So we got cost, we got effectiveness. But the real question is, are you getting your money's worth? Are you getting enough extra life years, quality adjusted life years, for the amount of money you're putting in? And so we compared these different strategies, just to enumerate them: BTS, ACCP, we compared Lung-RADS, and then we had some strategies that included just only looking at the PET scan result or only looking at the follow-up. And so you kind of put them all together in a group, and then you start comparing them. You say, all right, let's start with the lowest amount of quality adjusted life years, and then let's compare it to the next one that gives us the next extra amount of life years, and how much did it cost extra for that one? All right, now we do the next one. Oh, but actually it was cheaper for the next one. All right, so then that one is the one that's that we're going to choose as cost effective, right? So you kind of go down the line, you say, all right, which are the strategies that actually give me the most bang for my buck? And there are going to be strategies that give you some bang for a buck, but not nearly as much as another strategy. So actually, you're going to choose the other strategy that gives you the most bang for your buck, the most ICER, or the most quality adjusted life years, for the extra cost that you have to put in to do that strategy. So amongst the strategies we all tested, the only strategies that would be called cost effective, in other words, giving us that good bang for our buck, were the Lung-RADS strategy and the BTS strategy. So the ACCP strategy, while it had higher qualities, actually cost so much extra that it wasn't worth actually doing that. So that's to kind of lay the baseline. Now, it's a really great question about, the numbers that we see are all pretty similar to each other, and if you kind of multiply it out, you end up saying like, oh, well, there's only a couple of days of life years difference here on average. So, I think the best way to interpret it, I think there are many different ways of kind of thinking about this, but to me, the best way of thinking about this is, well, this is the average life years across our 100,000 patients. But most of those patients, actually most, it's a little bit more than half, have benign nodules. Well, it turns out pretty much no matter what you do to a benign nodule, you're going to get the same outcome, right? I mean, of course, there's some random freak things that happen, right? But for the most part, if you follow up a benign nodule, great, it's stable, right? If you go and resect the benign nodule, well, it was benign, patient's fine, everyone's happy, right? So kind of no matter what you do for benign nodules, nothing's going to change in the patient's life expectancy. Not exactly, but for the most part. So, and it's also true for a lot of malignant nodules. This is a 4-centimeter mass. Well, pretty much every management algorithm is going to pretty much shunt you, to surgical resection for your 4-centimeter mass, right? And so it's really, and that ends up being a bulk of the patients, a bulk of the nodules that you look at. So it's really a relatively small fraction of patients who are in that in-between zone, that middle zone, that zone that gives us all, keeps us up at night and gives us all trouble when we're reading the scans. And it's that fraction of patients in whom the different management strategies will yield dramatically different results and different life expectancies, right? Because if you take one of those nodules and it turns out to be malignant, but you think it's benign, and you say, all right, we'll give them a pass, come back next year for your next lung cancer screening round, and then it grows, a couple centimeters, and suddenly it's a new stage, well, then you really did impact that patient's life expectancy. So that relatively small fraction of patients is the key. And so if you look at an average, that is a small fraction of the overall cohort, so it doesn't change the average by very much. But for individual patients, it may change quite a lot, right? But if you look at the overall average, it doesn't change the average very much. So small differences in the average numbers, which is what we report in for qualities, may actually be really significant differences in a fraction of the patients.
Okay, so on average, we'll get more quality or more cost effectiveness for, say, in this case, the BTS management strategy for larger pulmonary nodules. Am I sacrificing anything in terms of accuracy, like nodule characterization accuracy, by choosing BTS over a different management strategy?
Well, BTS was the most accurate in our cohort,
All right.
Right, yeah, and that's really, I think, why it ended up winning. You might have wondered, are some strategies so actually comparing the BTS and ACCP is very helpful and to kind of flesh out answers your question, because those were the two most accurate models. However, the ACCP strategy resulted in a lot of resections for benign nodules. And so there were a lot of false positives. So, even though those were two relatively accurate strategies, there was a big downfall of the ACCP strategy that it ended up doing a lot of resections, which were costly for benign nodules. So, yes, in general, it's not simply just accuracy that we need to look at, but in this case, the BTS strategy was the most accurate, and that ended up being also the most cost effective.
Okay. And I guess as a review for myself, the BTS and ACCP strategies were those that use those risk calculators that we had mentioned earlier. I guess hypothetically, if it is more cost effective and the most accurate, we should be using these management strategies that include these nodule risk calculators. So can you expound a little bit further on the implication of this for how we should be managing these patients?
Yeah, that's a really great question, right? That's really what, at the end of the day, what the kind of point is here, right? Are we going to change our patient and our actual management in clinical setting? So I would say a few things about this. One is that in the simulation, it was a little bit stylized in that we use the algorithms as written down on paper, and of course in real life, there are individualized decisions that happen for patients. So probably in real life, things are working a little bit more efficiently than we assume on paper, just based on the sort of written word of a guideline or an algorithm. And the other important thing is that in this particular paper, we did not evaluate experienced thoracic radiologists. Now, in the original paper where we did characterize these 150 patients, my fellow Sumit Gupta and I looked at the actual nodules, and we saw that, as experienced thoracic radiologists, we did better, at least in the Brock model itself, and we did really, I think we had the highest accuracy of all the things we tested. Of course, experienced thoracic radiologists are not quite a dime a dozen, and so it really depends, I think, on your practice setting as a first question, right? So if you're an experienced thoracic radiologist, I think yes, you can continue to go with your gut feeling. You're probably at least as accurate as these strategies, if not potentially slightly more accurate. And so I think you can use your kind of intuition about what a nodule is. If you're working in a setting where you don't really do pulmonary nodules day in, day out, you're a general radiologist and you don't see as many of these, well, I don't know this for certain. We didn't check general radiologists in any of our work, but I would expect that you at least feel less comfortable triaging these nodules, and you may also just have less experience doing that. And so in those settings, I think that using a nodule risk calculator or using one of these even specific algorithms like the BTS algorithm would be something beneficial. And I think the other setting is, yes, let's say you are an experienced thoracic radiologist, but you're on the fence, right? And we keep coming back to these nodules where you're like, well, I'm not sure, is this benign? Is it malignant? I'm kind of on the fence. And I think in those settings, also using the risk calculator can help you push yourself over the line one way or the other. Yeah, let's get a PET scan here, or let's, biopsy this nodule, or, the risk calculator says it's lower. Well, we can maybe just wait a couple months then. So I think that in real life, there are two settings in which these things will be most useful. One is the sort of general radiologist, with less experience looking at pulmonary nodules, and the other is the experienced radiologist who is just on the fence.
Interesting. So let's say that I am working out in a general community practice as a general radiologist, and I don't have the same comfort that an expert thoracic radiologist would have. When I'm presented with this information that a management strategy that includes a risk calculator is potentially more cost effective, I then see that, man, it takes a lot of time and effort to start using these nodule risk calculators. Granted, they're not the majority of cases, sure, but it does take a significant amount of work to do. Do you think that the data you presented here, or even what's been presented in literature before, are enough to push imagers like me towards using these strategies?
Well, that's a great question. I think there are a few things you can think about. One is that, as you mentioned, this is going to be a minority of cases, right? Because the 4 mm nodule it's not really going to change too much, using the risk calculator. So I don't think you necessarily have to use it for these small nodules necessarily. I mean, that's not to say the algorithms and the risk calculators, of course, they apply to those nodules. But when the rubber meets the road, there's not going to be much difference between what you do for a 4 mm nodule with the calculator or without the calculator. Maybe you get a 1-year follow-up, maybe you don't. So I think if you're in a busy practice, I'm not pushing you to use the risk calculator for that setting. If you're looking at a larger nodule, then that's not going to be very many cases, right? We don't see that many large nodules, again, where it's a mystery. I mean, again, the 4 cm mass, right? Again, your risk calculator is not really going to help you there. You know what you're going to do. So if you're really, when you're presented with a larger nodule that's not so obviously malignant, that's the case. That's going to be a minority of cases. And in that setting, I think it would be helpful to use the risk calculators. For those of us who have access to UpToDate, that provides a very easily accessible BROC calculator. You just search in the UpToDate website for pulmonary nodule risk calculator, and it'll pull you to a page. You just type in the numbers and click calculate it, and it pops out with a percentage. So it does not take very long to use it for an individual nodule. I think also what I would say is that computerized decision supports are increasing in use across radiology, and this is the type of thing that would be very easily programmed into a computerized decision support system. If it isn't already, I'm sure it probably even is in some decision support systems that exist out there. So the extra time added is probably not going to be that much, and it probably won't be that inconvenient to do it, particularly since this is again going to be a minority of the nodules that we are confronted with.
Okay. How are you approaching these nodules personally? Do you include some of these quantitative values of based on BROC or Herder or whatever it may be in your interpretations, or you're an expert thoracic radiologist? I think that your gut may be sufficient as well, right?
Yeah, I generally continue using my sort of gut feeling about the nodules. But as I said, I mean, in cases where I'm on the fence, I think that this is a reasonable thing to turn to help you, again, push you over the line. But for me, in most cases, I feel comfortable enough saying, all right, I think this is probably cancer. I think it's probably not, and can go from there.
Excellent. Do you anticipate any follow-up work or future related projects in this realm, or are you familiar with anything upcoming in the same world?
Yeah, well, our group, Dr. Kong and I, have been working on other projects looking, as I alluded to earlier, at subsolid nodules, in other words, ground glass and part solid nodules. And we've published some work, cost effectiveness work on that. And we have another paper that's currently under review looking at different treatment thresholds for subsolid nodules. And those nodules are a particular conundrum, even more so than the solid nodules, because they have a very high risk of malignancy, but they are very indolent. So even if a pure ground glass nodule is an invasive adenocarcinoma, it has a near 100% overall survival after resection, because the likelihood of that metastasizing is so low. And so really, in that setting, you run into the question of overtreatment. Sometimes people say overdiagnosis or overtreatment, right? So are we trying to treat nodules that will not affect the patient's life expectancy? And so that represents a big challenge and conundrum for us as radiologists, and more so, I think, for the pulmonologists and thoracic surgeons who see these patients, because there's a nodule in it. You might be convinced that it's a cancer, but is it going to benefit the patient to take it out? That's the real question. And so that's stuff that we're working on. As I said, that particular paper is currently under review. Beyond that, I'm not specifically aware, as I think you mentioned right at the beginning of our discussion today, cost effectiveness research is not that common in radiology. But I think radiology is actually one of the perfect settings in which to use cost effectiveness. We have a lot of different tests at our disposal, and our tests are used to guide clinician management in a lot of cases. But there is that sort of disconnect between, okay, we see something, then what happens next? I think that remains really sort of an untapped question, really unanswered question in a lot of cases, and more so for the incidental findings, right? So incidental nodules. There's some really good work from Dr. Pandhari Pandey at MGH looking at like pancreatic cysts, for example, right, which are another problematic incidental finding. So, these sorts of things in particular, it's a really important questions that need to be answered. And I think as radiologists, we're actually well positioned to answer this, although many of us don't have much experience in this particular field. But I think that's something we should be really trying to do more of.
Excellent. Any final thoughts before we conclude, Mark?
No, I think we've covered everything. Again, thanks for this opportunity to have me on and talk about this paper.
Of course. Thank you, Mark. Thanks again for coming onto the podcast, sharing your time and expertise. We really, really appreciate it.
Thank you.
And to our listeners out there, thank you guys for tuning in. Once again, I am your host, Praveen Ranganath. And if you like what you hear from us on the podcast, please rate, review, and subscribe to us. We will see you next time.